Very welcome. We start over. Hi, everyone. Welcome to the Healthcare Committee. It is Tuesday, February 28th. And this afternoon and tomorrow we'll be focusing on our budget to come to a conclusion of a budget recommendation from this committee to House Appropriations. So today we have a couple of different topics, one new, the rest kind of follow up. Then we'll start a committee discussion this afternoon, and then really focus tomorrow all morning on our discussion and prioritization. We have potential vote on recommendations after the House floor. My concern is on the length of the floor tomorrow. So we're going to be as active as we can in the morning. If we get to a conclusion, we'll do a straw poll then. And if not, we'll come back after the floor. Just to set the stage. So we have with us Nolan Langwell from Joint Fiscal Office, who some of us had some questions on the blueprint proposal. So if you remember, this is a 2-year pilot using one-time money matched by the feds. And it is to extend the community health teams, Dulce, and then using the hub to do more integration when patients come into the hub for other chronic issues they might have. So bottom line is it's really helping to enhance preventative services and integrating primary care, mental health, and substance use disorder into one place that someone could receive treatment at all or information on all. So Nolan, I'm going to turn it over to you to walk us through the numbers of this. And let me just set the stage. The way the budget documents look, it looks as if this is a $41 million 2-year pilot. It's not, but I want Nolan to walk us through the numbers so we understand.
Okay, great. For the record, Nolan Langwell, the Joint Fiscal Office. I have 2 sheets. They should be posted, but I'm going to do a share screen real quick. My goal today.
And I'm sorry, Nolan, while you're looking for that, we also have Representative Woody Page with us from Appropriations. He's on Zoom. And so, Woody, if you have any questions at all, just raise your hand or speak up.
So my goal today is to help you understand the numbers in the budget. If you have questions about the blueprint itself, I will defer that to Ginger Irish, who's in the room, and Dr. Soroyan, who's on the line.
Great.
But if you recall, there was a sheet that had all these one-time numbers, and they were all over the place. And they were ordered B1100A, B1100A, B1, B11, so, and then you had B1101. And so what I did here is I put the numbers together that belong together. And I have it in 2 formats. This first format is the format for which you're going to be getting your chart. And this is written in the big chart as well. That's up on Claire's desk. But so if you look at the top, you can see there's state and general funds columns that have been added. You originally have the amount. There was the amount of all funds. That was in the original version. The gray is what I've added. So you've got your general funds, your federal funds, your Medicaid GCF, which stands for Global Commitment Fund, and then you have your investment Global Commitment Fund, and then other special funds. If you look on the far left, you can see the section numbers, and you can see that there was just to give you some heads up, in the B1100s are one-time funds. So that's where all these one-time general funds are going to be. The 1100 is general fund only. The B1101 are special funds or other funds. So what's going to happen is we use general fund for, and then we have our federal fund match. Well, the general funds are going to show up in the B1100, and the general fund match is going to show up in B1101. And so what I've tried to do is put the numbers together so that you can see, oh, this number goes with that number. So that's the first piece. The second piece is when you look at the blueprint numbers, you see that there's $41 million. There isn't $41 million. What happens is that's a double count, and I'm going to explain to you why. If you look in the agency department on the left side next the section number, you can see where it's going. So if you look, you'll see that the first line, AHS, one-time appropriation, it's 8.8 million. That's the general fund. And then you can see the next line, AHS, 11.4 million. That's the federal dollar match. Gross together, they're $21.1 million. What happens is that when we do global commitment, it's matched at AHS. And then, so that's where the way that the global commitment works is that everything doesn't get matched in the department. Everything gets matched at AHS, and then it goes to the various departments. So when you see you might see in DMH budget, for instance, global commitment funds, it's grossed up. There's a general fund and a federal fund share. It's just not matched there. It's matched in AHS. So what you're seeing is the double count. So so the general fund of 8.8 is being matched with the 11.4. That's being done at AHS. And then what's happening is it's then being appropriated to two different departments that are going to be implementing the blueprint pieces. You can see DEVA, there's 15.5 million that's going to DEVA. And if you notice, it's in the GCF department because that's the total matched. And then you can see the same for the VDH. There's 4.5 million. Again, Medicaid match. If you add those two up, it's 21.1 million. So what's happening is the 8.8 and the 11.4 and AHS are being combined there, grossed up, and then they are sending the different pieces to the different departments. Does that make sense? So that's what's happening. So it's the same money, just shown in two different places in the budget because it's being done here and then it's being transferred over here. And then the bottom piece, you can see the one-time blueprint, the DEVA dollars. Now those are just admin dollars, and they're just being matched at DEVA. So they've got the general fund and they've got the federal fund, but they're just staying in-house.
Is that the 366,000?
Yes.
I don't see a federal fund number on that.
It's 366, and you look one more over to the right, 372.
Oh, that's not.
Oh, that's right here. Right here. Oh, right here.
So that's not on the one. Yes, it is.
Oh, the page cut. The page cut.
Okay, so it's.
That's one way of looking at it.
Okay, so 366 general and 372
Correct.
funds.
There's a note at the bottom of this that says, "Note, not sure why numbers do not match." I actually do know why they match now, but I didn't know when I did this. I had a nice conversation with Rich Donahue, and he explained everything very clearly to me. So hopefully I will articulate to you. Look at the second page. Hello? Second page.
So wait, do you see which numbers don't match? Let's do that first. So they give the AHS central office of 20.2 million and the DEVA and VDH of 20.1 million.
So if you go to the next page, it's weird with, it's good, I see. All right, so again, this is the same thing. So what I've done is I color coded the 1100, B1100 and B1101 so you can see where the moving pieces are. And you can see in the AHS central office, there's the 8.8 and the 11.4, and it's combined to 20.2. And then then it's global commitment when it goes to DEVA and VDH, and it's 20.178. There's a $60,000 discrepancy. It's basically, long story short, they were trying to work with a number, $9.2 million in general fund, and it wasn't perfectly matched. So there's a little bit of a $60,000 carry forward, but if you recall, it's a 2-year project. We don't know what the blended match will be in the second year. Generally, the FMAP could be going up, could be going down. So it'll be used. It's basically an accounting discrepancy that's really, as I would call, budget dust.
Yeah.
That'll just sort of get carried into the following year. It just has to do with trying to fit everything into the box. But essentially, it's the same money. So I don't know if
Does that help everyone? Or at least it helps me. So,
It's a lot, thanks, Nobody.
okay.
all right.
So if I may, the second page is not in here? Or-
No.
Okay, got it.
I did, the first page was just so that it matches the format. So when you see it in here, when the bigger one, you get it. And the other one was just my way of trying to say,
No, that's pretty helpful, so I'm thinking of printing it. I just wanted to
yeah.
keep it together.
So the cost of this piece of Blueprint for Health is 20.2 million.
Correct.
Over 2 years.
That's all
Over
that
2 years.
matters.
Yep.
So if you recall, Dr.
Say that
Soraya,
again?
Over 2 years.
For 2 years?
Yep, so it's a 2-year pilot, so it's about 10 million a year.
Okay,
So Dr. Sarayan, he came in, he says 10.5 million. He was talking per year.
okay. All right, so now didn't we just?
Ellen, can you take that down in case we need to ask Dr. Sorin a
Didn't we
question?
just do a pilot?
With Blueprint?
Yeah.
I don't-
Have we not done anything with Blueprint? This is the first money we're putting into.
Oh, no, this is,
Oh, no, this is,
an expansion.
yeah, this is an expansion of Blueprint. So if you remember, Dr. Sorin came in, I don't know, maybe 2 weeks ago. I know, it's hard to remember.
Well, I remember coming in, but trying to fit all this into my head.
Yeah, so again, this would expand Blueprint. It would expand the community health teams, the
Okay,
Dulce program, and then provide at the hub where people are coming in. It would also allow for the hubs to, instead of saying to someone, oh, well, you have, high blood pressure, I'm just making this up, but it's an example. You need to go back to your primary care. There might be something at the hub that can be done so the person doesn't have to go to 2 places. And Dr. Sorian, if you want to jump in on anything we're saying, please do.
Oh, sure. I think that was very on point. Thank you.
Okay, great.
okay.
And stay, if you can, Dr. Sorin, stay on because we might have a couple more questions. Alyssa?
I'm just wondering where the Dulce appropriation is in this. I mean, everything's
It is-
labeled hub and spoke.
It is part of this. So it is labeled hub and spoke, but it's part of this.
It's part of it.
Yeah, so the 10.5 includes all three. It includes the hub and spoke expansion, the CHT expansion, the
Dulce.
Dulce, and then some analytical, a piece of it with the quality team. I forget what they're called.
That's right. Representative Black, did you want me to add anything else? What Chair Houghton said is correct.
No, I was just sort of hoping that there was a bit of a
There is.
breakdown.
If you look at his presentation.
Okay, great. I'll look at that then.
Yeah.
Thank you.
Leslie?
I'm just wondering about the 2-year process. Does the second year get guaranteed? How does it work that the second year is guaranteed in the budget next year? How does that work?
So if and Will won't help me here, but if it's passed all the way through and signed by the governor, the money will be allocated for the 2-year project.
So it's automatically included in the next budget, in the governor's ask? How does that work?
Because we're appropriating them the money upfront.
So it doesn't even come into his budget next year then?
It won't have to,
Okay, got it.
unless they have an adjustment of some sort. We're giving them the money this year for them to spend over a 2-year period.
Okay, thank you.
John, I actually have a question for you, and I apologize if this was asked when you were in before. So 2 questions, actually. I'm wondering what will be available to this committee and the legislative body after year 1, or at some point for a check-in on what's happening, and if that's something we need to put in language. And then 2, it's a 2-year pilot. Granted, we move forward with this. What is the expectation of how and when we could make it permanent? And I'm concerned about pulling back the resources after 2 years.
Sure. I think I will do everything in my ability with our team to make as much available in executive committee, in our annual report, and as invited in testimony next year. That would, I imagine, be how things are going specifically around hiring. I would, if I were in your position, that would be a top question of mine. Of these monies are available, these positions have been posted. Blueprint is being more specific about how some of these dollars are being used related to the Dulce program expansion to community health teams for more specific types of personnel and what's going on in the hub. So I would imagine a similar group as was invited, I think, when Dr. Levine, Elisa, and I spoke to speak to programmatic aspects. I would expect I would be able to tell you all what have you set in place for evaluation? That certainly would be there too. But those would be my general categories for your first question. And then the expectation of the 2-year pilot. I'm not sure how far into the future I'd be able to say. I would imagine perhaps parallel discussions with the secretary and the governor's office at the year 1 mark, similar to what we would be saying to the legislature to evaluate whether it would become incorporated into faith. Again, these things are new to me, but that's what I would foresee based on what I've experienced thus far. I'm not sure if that gives you some insight, but please tell me if not, because I'm happy to get more answers for you.
It does. I'm just curious if you have in your timeline and process, when you would start to see the first data results that could show, yes, it seems like it's helping, it's doing this, no, it's not. So we can determine when we might be able to start the discussions of whether or not it
Sure.
should be a permanent.
In terms of the hiring aspects of it, because I know that's an area of focus, is that is updated in our Blueprint portal by our administrative entities as people are hired. So that aspect of it, I would expect to be quite brisk and current. More formal evaluations from perhaps individual experts that we contracted with to look at outcomes. I imagine what you're getting at is that might not be available for, let's say, people who were served during this period for the second half of 2023 and all of 2024. You're right, depending on the payer, because those outcomes are different, have different lag times based on the payer. Medicaid, I imagine, is where we might be looking first, and then commercials too, since we'd be collecting their data and serving their individuals, even though we're not recommending their participation. You're right. That would be a year and a half, maybe right at the 2-year mark. So there is some. That's a tight time frame. You're right. Okay. To really be able to give you all of the information. I would certainly push as hard as I could, but you're right. There's some systems involved in this that doesn't matter how hard you push, it just takes longer for that data to come through.
Okay, thank you. Does anyone else have any questions on Blueprint?
Lori, you might have mentioned it, or John might have mentioned it. How many folks are we hiring for this? Do we know, or?
Sure, I can give you estimates. I think with the investment from Medicaid, in terms of the community health team expansion, we're looking at anywhere from 2 FTEs in some of the more less densely populated health service areas to as many as 16, 17, or 18 in a more densely populated area like Chittenden County. Total with Medicaid investment, we're looking at being able to fund, depending on how salaries are plugged in, as many as 50 or 51 folks around the state. The asterisk, I'll add to that, or the parenthetical, if you will, is that we know that there are 10, 15, maybe even 20 people on community health teams today whose funding and whose time could be expanded without actually recruiting someone new. So that's something that we've been looking at in terms of our own group. So while I might say that there could be 50 or 53 people across the state, I'm expecting that 10, 15 of them may already be in existence, but just wanting more time. For the investment in the Dulce program with the Medicaid investment combined with community health teams, I'm expecting that would be another 12 or 13 individuals who could be funded, again, depending on the salary.
So, and pardon my ignorance here, but so this money is going to salaries to the people that carry out Blueprint, essentially, correct?
That is when I look at how the different monies are invested, that is the greatest portion of the dollars, the 5.98 proposed annual investment per 2-year pilot. That is the, if you will, the bulk is for people who will be providing these direct services. That's I think one of the appeals to many people about the Blueprint program is that direction of funding really goes to people on the front lines, if you will, in the trenches, depending on what expressions you use, who are serving Vermonters.
Okay, thank you.
Of course.
I'm just wondering about, I just want to see the number. I think you said 5.98, and I'm just looking at that budget. I'm trying to connect the dots. So you may not be looking at something different than Nolan just gave us. So I'm just.
So in his presentation that he gave the other week, he has a breakdown by piece of the dollars.
Yeah.
Go back and look at his.
I was just wondering where in this it sits.
In where, in this?
In what, yeah.
This is just the total.
Yeah, so I was just wondering where in this is what he's talking about, because it's like in the 11 million, in the 8 million, in the 15 million. I'm just curious about that. Does that make no sense to anybody, I
It
guess?
would be in the 15 or the 4.5, if that's there.
Yeah, thank you. I'm just curious about where that.
Where they split out which resources they're sending into each plan. Because remember, the work is being carried out in DEVA and VDH. So it's being helped in the 15.5 or the 4.5.
Thank you.
That's where the work is being done.
That's really helpful. Thank you.
The top part is just the mechanics of the funding.
Okay, thank you.
All right, I think we have one more question, Alyssa.
Specific, to sort of follow up on Art's question, do you anticipate of the expanded community health teams, which professions you're really looking to expand?
Thank you. From the discussions we've had within our teams, our discussions with different folks, including the Department of Health across the state, I have evidence in multiple different parts of the state to say that community health workers will likely be the type of, and there's certainly discussion to have there about who constitutes a community health worker. But my guess right now is that will be how many of these positions are filled, both in Dulce and on community health teams. I do believe that counselors and social workers are just for everyone. I mean, it's a national as well as state thing. I think those will be the hardest individuals to recruit. And then, as I said, I think in the previous question, however, there are counselors and social workers in our current Blueprint teams who I would very much like to see more of their time funded to do social work and counseling work, if you will. Sorry, my camera's shaking because I kind of move when I speak.
Thank you. And can I just make an editor? Am I the only one that every time we talk about appropriating money to certain professions because there is a workforce shortage and we're trying to attract those people, that we're then stealing from another organization that is also desperately, I mean, I'm thinking about if I'm a licensed clinical social worker and we appropriate 5.98 million to Blueprint, I could work on a community health team through Blueprint for a lot more money than I can work at a Howard Center, one of our DAs. So, I mean, I just, at a certain point, we're sort of eating our own here.
The designated agencies do receive through pass-through dollars and arrangements with our administrative entities dollars to hire people, which I think in several communities that I visited, I mean, to me, almost represent the epitome or the ideal of having someone in primary care, but also in the subspecialty space. So I'm hoping, and certainly disagree with me, but I'm hoping that this can be an all boats rise type of situation. My intention is for this to make everyone be able to do that recruitment better while serving the integration purposes of this as well.
And I think that brings up a good question that at some point this committee should consider taking up, which is all the various programs that we have run by different areas that are potentially duplicative. what's the quality? What are the metrics around them? Who's producing the outcomes that we as a state value? And how does that connect to where we are putting our money? So it's a really big conversation. We're not going to have it before tomorrow, but it is something that is, we should start considering looking at. Great. John, thank you very much. Appreciate you coming in on short notice.
You're very welcome and good to see you all. I'm sorry I couldn't be there in person, and thank you, Nolan, for your explanation. I learned a lot too. So thank you all.
Thank you. All right, next we have Mike Fisher, who has not yet weighed in on all of our budget asks. So he's gonna come to the table and talk to us.
I haven't.
Well, maybe from the sidelines. I'm not sure you've been in this.
Good afternoon. Take my mask off. Good afternoon, Mike Fisher, healthcare advocate. So I thank you for the opportunity to come back to the table and say a few more words about about DVHA's budget ask. I think I can be fairly brief. I do want to start with a high-level expression of, hey, we at the Healthcare Advocates Office have a great working relationship with DVHA, both as an organization and the individuals who are, working hard every day. Even before any consideration of changes or any consideration of new challenges in front of them, like the redetermination process, I always have an interest. I always think that I should come to the table and say, on a base level, we're always concerned about whether DVHA is well-funded enough, whether it has the full staff to be able to meet the needs of the tremendous population of Vermonters that depend on them. I want to be really clear. I don't want to in any way criticize any individual for not doing a good enough job, but we watch them be tasked with too much. And as we're a partner with Vermonters and DVHA trying to work through details, there are times on a base level where we have that concern. I just wanted to start with that. Layer on top of that redeterminations. The redetermination effort is a tremendous one. I'm not sure we could overstate it. It's over 200,000 Vermonters who we haven't been in touch with, who we now need to be in touch with to make sure that we reach them appropriately and that we evaluate that they are still eligible for Medicaid, and if not, that they get moved to the right plan. I'm bracing myself for my team. This is going to be an effort for us. But I wanted to just say, hey, I recognize the advocate's office comes and says, we want DVHA to do this and we want DVHA to do that. And we do. But I also need to recognize that this coming year is a big challenge for them. It's an all hands on deck challenge. And so I wanted to say that before getting into some of the details of the budget. You have already heard me on dental. And I will restate that we continue to hope that the committee can pursue an eventual, notice a change in my language here, an eventual elimination of the dental cap. We still think that's the right thing to do. I recognize I've just now have looked at the presentation from DVHA. They're going to come and talk about an increase in the dental cap with the recognition that it's hard to predict exactly how it will play out. In the all of 3 minutes that I've looked at it, I agree it's hard to understand the moving pieces from the last time we increased the dental cap, given COVID. So I think the right thing for me to do is to accept the proposal as an important step forward, with an added request, and I haven't really thought this through completely, so let me just say it and I can think about it later with members. I still think the right thing to do is eliminate the dental cap. And so I wonder if there is an opportunity for us to do some legislative intent here to state that as a goal. Accept the change from $1,000 to $1,500, the dental cap this year, and call on DEVA and future legislatures to evaluate how to move further.
Would you like to provide some suggestions on intent language?
Absolutely.
Great. For tomorrow?
Before tomorrow, absolutely. I would be happy to.
Thank you.
Okay.
And we, just so everyone knows, we are hearing from DEVA at 2:30 about
Yes.
their proposal.
Yes. Let me do the over-the-counter medications one next. I've not talked to you about DEVA's proposal to eliminate coverage for over-the-counter medication, antihistamine, vitamin D, and melatonin.
So I know you don't have the chart in front of us, but are we talking about the Eliminate Vermont Cost Sharing Reduction Program or the drug coverage changes with pharmacy benefit?
Latter one.
The drug coverage changes with pharmacy benefit.
Yes.
Which is under the DEVA section for those following along, B307,
I heard,
1.7 million. Sorry, go ahead.
I heard DEVA's testimony that this was characterized as something like this was the least bad thing that they could do in order to meet the budget. And absolutely respect the parameters put on them in developing the budget. We still think this is bad for Vermonters. We still think that we should cover these medications. I think this is a very low income population, and I'll just point specifically to antihistamine. I don't personally struggle with this, but I hear people who talk about how important access to antihistamine is for them to live a reasonable life. And so I just wanted to go on the record as opposing that cut.
Art?
I'm trying to understand that, Mike. This is a negative 1.7 million. And what's that proposing to do to cut?
That is eliminating DEVA's coverage of over-the-counter antihistamine, vitamin D, and melatonin medications.
For Medicaid?
Yes, for people on Medicaid.
Medicare?
Medicaid.
Medicaid, okay.
Yes.
All right.
So these are all people, well, these are people who qualify economically for Medicaid.
Right.
So I would say they're very low income people who.
Do we know how much those things typically cost?
I think you have a price tag right there, 1.7.
Right, I mean, that's the overall, I mean, if somebody was to go into a store and get those items, I wonder what they are.
Yeah.
I mean, how much money we're talking for a person who comes in.
Yeah.
Curious.
Yeah.
No idea.
I don't know.
Antihistamines are for asthma, correct? Or no?
No, allergies.
Allergies, right. Sorry, thank you.
Yep. I would have follow-up questions about how much it goes for each of those three different medications and sort of parsing it out. But I think the right thing for me to do is just say on a high level, we are not supportive of reducing that coverage. Okay, finally, I wanted to talk about the cost sharing reduction proposal.
That's the 500,000.
That's the 500,000. And I think it is $1 million, but because it is proposed to only take effect for half the year, in the budget proposal, it only shows as 500,000. But the annualized amount is $1 million.
Can you show us where it is on this?
Next page. Oh, I'm sorry, I'm on this.
B309 under DEVA.
E309.
E309.
Thank you.
It's also highlighted in, well, I don't know.
Oh, yeah, here it is.
Highlighted in green.
Got it. Thank you.
So let me first start on a policy level, and then let me do a process, and then I'll go back to a process level. On a policy level, this is, we are not fully supportive of this. It's not a blinking red light, it's a blinking yellow light maybe. We think that there is a modest negative impact for a set of Vermonters. But we also, members of the committee, this is tricky because if you haven't noticed, healthcare is complicated. And there are moving pieces all over the place in healthcare that impact each other. And so I need to just reference something that I will spend hours with you to describe at another time, but will not describe fully here because it's too complicated. But there is a moving piece that is happening over at the Green Mountain Care Board that is known as silver alignment. It is a way that the plans are being rated. We have proposed a change about how to appropriately rate silver plans in the exchange. The Green Mountain Care Board is actively considering that, and I believe moving forward to in the way that we recommended. If that happens, all of my concerns about the CSR proposal here evaporate. There's a strong positive that will that eliminate any of my concerns. So that's my hesitation on the policy level. If it goes away over in other places, I'll be coming back to you. But at the moment, I'm feeling confident that it's moving forward. So back to the policy, to the process level. Let me go back to what I said originally about the burden in front of DEVA, the all hands on deck dynamic in front of DEVA with the redetermination process. I don't know exactly what is entailed on DEVA's part, what the lift is on DEVA's part to accomplish the CSR change. But I'm understanding that it's not small. I think you'd have to ask them to understand exactly what it is. And so I do want to go on record as saying, hey, the most important thing in front of DEVA for this coming year is doing a good job of redeterminations. I don't want to pull them off of that job. And so if there is any concern about the task of accomplishing the reduction, the elimination of the cost sharing reduction this year, I'm opposed to doing it this year. I think it would make sense to postpone that change.
And unfortunately, the silver loading and all of that, I mean, that is something that would take a long time for us to get our hands around. It cringe when I hear that word, quite frankly.
And it's even not silver loading, it's silver alignment.
Right.
Silver loading is a different thing.
But right. So anyway, see, so unfortunately, we're going to have to look at this in a broader conversation of this is one of these things that we just are not going to have all the information on. But I value Mike's opinion on, what would need to be done by DEVA on this, and we can ask DEVA when they're here, and also the fact that we do have all of these redeterminations we have to do. So
just to be perfectly clear, the HCA's position is that if the elimination of cost sharing reduction will take DEVA off the job of doing a good job on redeterminations, we don't think it should be done this year.
Okay. All right.
Help me understand my cost sharing reduction. What are we talking about?
So generally, cost sharing reduction is a program that helps low income people on the individual market in the exchange have lower out of pocket costs.
Okay, so it helps.
It adjusts the plan.
It helps them with their out of pocket costs.
Yes.
Folks that can't afford insurance, but they're at the low end.
Yeah.
So we're helping them with that out of pocket cost.
Yes.
Okay.
Okay. Yeah. Sorry.
So that's what I have for you.
Great. That's it.
That's
great. Wonderful. And Art, back to your question about how much these things cost. We are having a pharmacist come in to talk about the drug coverage changes.
Okay, all right, yeah, good. Thank you.
So sorry, I meant
And,
that earlier.
and I really mean it, if you want to spend an hour over a drink of coffee or something else to talk about what cost sharing reductions really are
Yeah.
and refinement and AV value. I love that stuff.
I wish I shared your love, Mike.
Me too, Art, me too. So is Jeff joining on Zoom?
Yes.
He's here? Okay, great. Oh, he's not here yet. Okay. So, and is the commissioner joining in person?
Yes.
In person and not here as well yet. So let's take 15 minutes or whenever Jeff gets here, that he will be our next witness at 2. So does everyone have this chart? We printed copies. They're up there by Claire. So let's maybe align ourselves to what we have in front of us because we'll use this tomorrow and later today with our discussion. So the first page, you'll see at the top, it says not in governor's recommend. Does everyone see that? Bobby, are you good online or?
I have the online version, but I'm about to go grab a physical.
Okay, that's.
If I may ask, is there a draft number or a date, just so we can mark them?
There is not, no. But I think everyone has the same one because it's what I asked Claire to print. So first page, not in governor's recommend. So these are all the items, it goes on to the back side, of requests that we have had that were not in the governor's fiscal year 24 budget. Okay, so these are all of the requests we heard for Medicaid rate increases, from primary care, it's the EMS data, it's Vermont Care Partners, it's home health agencies, and it's by state. And the last one before the next section is VSAC, which we heard about the Nurse Forgivable Loan Program. I'll update us on that in a second. So then.
I have another question.
Yeah.
When we're being asked to rank, is it only this top group that we're ranking, but not the governor's ask, or we're ranking all of it?
We are ranking everything.
Right.
Yes. So on the next section, it says there's a $sign in sections. So all of this was in the governor's recommend, and it's all the money associated with the recommend. And you'll see that it has the section numbers, and the second column is the agency. So we have DIVA, and I highlighted in green just kind of the bigger ones we've been talking about. So this is the dental rate increase, the drug coverage we're going to hear more about. The mobile, those are the 3 biggest ones for DIVA. And then you have DMH that starts a little bit towards the bottom. That's the Mobile Crisis Center. It's Mobile Crisis Response, sorry. The 988 suicide line funding, peer support credentialing we heard about on the next page. And then the therapeutic alternatives to EDs in the Northeast Kingdom that we heard about. Then you'll see a yellow line that says one time. So everything that I just talked about would be base funding. We would put it into the base budget. So it would live on until it's taken out. Okay, so if something is $500,000, that would be $500,000 ongoing. The next section, of which there isn't as much, is one-time funding. These are just one-time dollars that is in the governor's recommended budget ask. And in here, we heard from the Secretary of AHS on Friday about the $10 million for emergent circumstances impacting healthcare providers. And then we also have some movement of Medicaid funds in here, which we can talk about. There is one row on the one-time money that's highlighted in like an orange color, if everyone has a highlighted section. B1100A18 for VDH. That will actually be something House Human Services comments on and puts in their budget. It won't be in ours.
Now, on that page, Lori, is there any Oh, okay, I think I see. I didn't think the lines continued over, but I see now.
Are you good? Okay.
Good.
That's, and then the one-time money is where the blueprint we just talked about. And then the very last, well, the last page and a half, this is all language. So the language could be referencing dollars from a previous section, or it could just be language. For instance, reserving money for the 53rd week. We're not going to spend a lot of time on the language, although there's one important one in here. E300 is the language that funds the Healthcare Advocates Office.
What about it? What about it?
The 35 limited service positions. Is that something you want to talk about?
I'm gonna ask that, yeah.
Okay. So anyway, so for now, I just want to kind of get the lay down of what we're looking at. Some of these we've talked about before, and as we walk through it, we'll notate them. I mean, they're kind of, we have to do them. So we won't necessarily prioritize those, but everything else we will prioritize into, not really sure yet if we'll do, our top couple we want, or if we'll do groupings of like high, medium, and low priority. We'll think of that as we go through. Art, and then Leslie.
The columns say Medicaid GCF. GCF is,
Global Commitment Fund.
gotcha.
What is the difference between that and the federal funds column?
The federal funds, so it's grossed up money. So the GCF already has the state and the federal fund combined. So again, if you go back to the blueprint conversation before, it was state funds and federal funds matched up, and it was appropriated to VDH and DEVA as general global commitment funds. So it's already matched up when it's in the global commitment line.
Okay.
It's already grossed up, it's just been matched elsewhere.
Okay. So now that we don't worry about the dollars that are coming into us from the federal government, the state general fund column, right, that's our budget. So when it's a state general fund, that is the state of Vermont budget. So for instance, if you look at the very first one on the very first page, we're saying that $294,360 of state dollars would be put forth for that program. Medicaid Global Commitment Fund would be another $382,000, but our state dollars, $294,000. Leslie, you have a question?
Yeah, I was just thinking about, you commented that some things we don't have a choice. And so I'm sort of want to go into it knowing what those are, so I don't spend any time thinking about it.
We can do that at 3 when we're done with testimony.
Thank you.
Yeah.
Or whenever we're done with testimony. All right, what other questions?
Who came up with this whole format?
It was Joint Fiscal Office, it was Nolan, it was Daisy, it was
Okay.
me, it was,
I just want to compliment them on this. This is
yes.
excellent.
Thank you very much.
This is
Well,
what
it's-
I need, I know, to at least look at the thing.
So since you've been here, we've used something like this in our committee. In the past, it's been a letter that we've put together, and I think this works much better because we can lay it out and see everything. So good. So if we have another version, we will make sure we date it and put a version number and make sure everyone has the same copies and go from there. So, is Jeff here yet? Okay, but the commissioner is, so do you want to go early?
Happy to.
Okay, great. Come up and join us. You, Jeff. Okay.
Would be 2%. 3.85, 10% is like.
Nice to see you. It's a nice
winter day.
Okay, thank you.
I
That's,
just looked at the calc, so that was in there, but I
okay.
just ran the model and that's.
Yeah, because that, yeah, okay,
We can fill that in later.
okay.
I haven't heard the forecast. All right. Lots of.
You know, I'm asking the commissioner to go, but do we know if, you know what?
You want me to wait?
I should probably as much as I want to move things along, we should probably wait. So